Good Sunday morning. This is the Canon Hospice Radio Hour. I am your host, Elise Spencer, Community Liaison for Canon Hospice. Well, we're wrapping up what has been kind of a week of intermittent but heavy rain, and looking forward to sunny skies in the coming week. On the Canon Hospice Radio Hour, we talk about relevant medical healthcare topics and try to share with the community some of the expertise of the many individuals that work in the healthcare profession. This morning, we are going to meet the staff of Canon Hospice. We have a recently promoted staff member and a couple of new additions to our staff, and we are so excited that as much as is possible on the radio, we can acquaint you with our staff and our services. So, first of all, I'd like to welcome to the program Kendall Diaz, RN, MSN. She is Canon's Director of Nursing. She's been a nursing instructor with the University of Southern Mississippi. She is retired from the U.S. Air Force. She's been a nurse for 12 years. Her Bachelor of Nursing degree is from University of Southern Mississippi, MSN from University of South Alabama. We're so glad to have you on the program, Kendall. Welcome and good morning.
Good morning, Elise. Thank you so much for having me.
Well, I think it's really important as we initiate a discussion about hospice services for people in the community to know what hospice is. Many people have kind of a cursory understanding, and many people think that hospice is just a place for patients when they are dying and nothing else can be done. But in fact, hospice is a specialty healthcare profession, and there's a great deal that we can do for individuals who are facing the critical point in their life where they are suffering from an end-of-life or life-threatening illness. Tell me some things about what hospice can do for patients in that situation.
Well, I think that a lot of people are afraid of hospice. They're afraid of the hospice word because it does infer and refer to death. Hospice embraces the philosophy that death is a natural part of life. It's just the end of life. So what we do in hospice is we try to make those last days as comfortable and as pain-free as possible. It is for people, patients, who require not only palliative care, but that they have a terminal diagnosis. So we do ask for a physician to state that the patient has 6 months or less to live. Now, there are times where that doesn't happen. Patients outlive that 6 months. And of course, if you're entered into hospice and you do go into some kind of a remission situation, you can always leave hospice and have other services.
That's true. Sometimes patients do stabilize or tend to improve, or they simply decide that it's in their best medical interest to resume active or curative therapy, and that's always an option for patients should they choose to do so.
That's true. Hospice embraces a team approach. We have an interdisciplinary team of not only nurses but aides. Canon does have an inpatient unit, although we try to use that to bring patients in-house when the families need a little bit of rest or maybe to transition to go home. Primarily, we want hospice patients to live in the home with the family so that the family can help take care of them. We have chaplains, social workers, a whole team of people, including volunteers, that help the patient and the families and their friends to cope. And we train them to actually take care of their family member.
It's really nice to know that hospice is a program that helps provide some of the more technical aspects of a patient's care so that it frees up the family and loved ones to simply surround themselves at the patient's home and provide tender, loving care. That's, I think, what we would want for ourselves and really anyone who's suffering from a pretty critical illness, that they have lots of good time with family and friends.
Exactly.
Together.
And you mentioned in the beginning that hospice is a specialty. It certainly is a specialty. It's just like if you have a baby, you go to specialists who are trained to deliver that baby safely and take care of the child. If someone is dying, it's a phase of life that they're going to go through, and you don't just want to ignore that, just let them lay there. You want to make sure that the patient is comfortable, that the family is comfortable, that people are taught to begin and go through the grieving process. And I believe you're going to talk to someone else about that in more depth. That's not really my area. My area is more the nursing part. But it's just so important that we have all of these different disciplines to cover those different areas with the families.
One of the things that I hear sometimes as I'm going out to speak to families or community groups about hospice is that they think hospice is primarily driven by this philosophy that we need to provide a very generous amount of pain medication and essentially make someone so medicated that they no longer have an awareness of their situation or the presence of their family members. And it is not just a medication regime designed to take care of critically ill patients. It's really a whole constellation of things that comprise hospice.
Very true. Just the word comfort. Comfort doesn't only involve or encompass pain-free, although certainly if you're in pain, you're not comfortable. So hospice nurses and staff, as part of their specialty, are trained to provide the correct type and amount of medication to take away or lessen that pain. But comfort has to do with so much more. Comfort has to do with repositioning, with keeping patients clean, with just simply looking at them and wondering, what can I do to make them feel better? Sometimes comfort is helping them change the channel on the television or talking to them about, well, do you think it's going to rain today? And making them not feel alone.
It's really maintaining a presence with them and being available to them to encourage their dignity and
true.
Their right to make choices.
Very true. But make no bones about it. If the patient needs pain control, we do that. Mm-hmm. And a lot of other specialties might be reluctant to provide the pain control needed. And the different types and regimens. And sometimes it's a combination of different things, not just narcotic pain medications, but things to help with sleep, things to help with nausea. There are a lot of things that go on in the dying body. And we try to address all of those things so that we don't just simply give them narcotics to make them sleep all the time.
Well, as you mentioned, there are a lot of symptoms that can be effectively managed through medication and support. Some of those other symptoms that you talked about are sleep or nausea, but that would also extend to agitation, restlessness, anxiety, constipation, difficulties in urination.
And a whole range of respiratory issues as well.
That's a good point.
Not only oxygen, but respiratory treatments, suctioning. We try to keep our treatments and the things that we do as less invasive as possible because we are looking to make the patient more comfortable. Mm-hmm. But we also don't want to leave them in a state where whatever's going on is causing that discomfort. We also think about the discomfort of the family. And that, when you think about medical care, you think about treating the patient, but in hospice, we have to treat the whole patient, the whole family, all of their friends. So we don't just focus on the patient laying there. We talk to the family. We provide them spiritual guidance. Of course, that's not to take the place of their own pastor or their own church because we know that people have their own beliefs. And let me back up. Hospice isn't based on any one belief system or religion. If you have no religion or no beliefs, then that's okay too. It's whatever we can do to give the families hope for the future and understanding that this is a natural part of life.
And in turn, when we can provide supportive services to a patient's primary caregiver, the individual in the home responsible for most of the day-to-day hands-on care when our nurses aren't present in the home, their family members or their extended loved ones, when we can teach and support those individuals, they in turn have greater capability and capacity to interact with the patient and give the patient what he or she needs.
Yes, just like with anything else in life, we can empower people to feel like they know what they're doing and they don't feel helpless. It's like with teaching somebody how to jump your own car if the battery dies or change a tire. If you feel empowered that you're capable to do that, then you're not afraid. You know, if your mother wakes up in the middle of the night and she's in pain, you know what to do because we've taught them. Our nursing staff and our aides that go to the home and in-house are very, very good at teaching. That's one of the primary things that we as nurses in all realms of nursing do, but especially in hospice. We need these families not to feel helpless or afraid.
That's a really good point. What are some of the medical conditions that we serve in the hospice community? What kinds of diagnoses do we see?
Well, of course there are cancers, and cancer is the primary thing that we deal with because it can't be cured most of the time. I mean, there are a lot. No, let me say that. There are a lot of times that cancer can be cured. But when it gets to the point where there's nothing else you can do, then that's where we deal with that. Of course, there are other issues like congestive heart failure, respiratory issues that really aren't things that you're going to die from very soon, but they just progress and take some time for that to happen. So we spend a lot of time educating the families, educating the patients on the best way to deal with that.
So we also see a fair number of patients in our practice who are suffering from maybe end-stage organ failure, kidney disease. HIV is another one.
We do. We don't have many of those patients, but we do have HIV/AIDS patients, and that's a whole other little specialty in itself, a whole different set of symptoms and things that happen. Not to mention they're with family members and other there's a stigma attached to that sometimes that we have to overcome and help to educate. We have absolutely nothing against anyone about any disease that you have or how you might have acquired it. For example, we have lung cancer patients who want to continue to smoke. Now, some of you are saying, oh, why would you do that? But, people have a right to do that. So if you're in the end stages of your life, you have the right to smoke just as well as you have the right to eat peanut butter and jelly sandwiches. And we respect that. And we embrace that as well as the families and try to educate the families that they have the right to these behaviors.
It's a pretty interesting thing that, throughout our lives, we're a society that really prides ourselves on self-determination. We get to make choices. We like to choose. We like to make sure that everyone else knows what we decide, what we will and won't do. Or, and even in end of life, patients retain that right to say what they will and won't do, what they choose to have done with regard to their medical care or what they decide to consume, nutrition-wise during the course of a day.
Yes, and there are times when those thoughts conflict with family thoughts, with what families want them to do. And there are also times where the patient can't make decisions for themselves, that the families conflict with each other with what they think should be done. And we in hospice mediate that. We spend a lot of time listening. The nurses listen. Of course, our social services department, our social workers are just wonderful at that, and I believe you're going to interview one of them in this show too, and she's just wonderful at that. We just listen a lot. It's not so much if you've ever had a family member in the hospital where the nurse seems to fly in and fly out, because they have a lot to do. In hospice, it's not. We have a lot more time to take time with the patients and the families and disciplines to help us with that.
Very good. Well, we're going to be back here in just a moment. You're listening to the Canon Hospice Radio Hour. My name is Elise Spencer. I'm your host today. I'm joined in the studio by Kendall Diaz, RN, MSN, and our Director of Nursing. We're so glad that you're with us. We'll be back in just a moment. Welcome back to the Canon Hospice Radio Hour. My name is Elise Spencer. We're on the air this morning with Kendall Diaz, Director of Nursing for Canon, during our Meet the Staff segment. Kendall, before the break, we were speaking about some of the diagnostic criteria for patients getting referred to hospice, what the hospice philosophy is, and how it entails a team-based approach directed at not only the patient, but the whole constellation of the patient's family and loved ones. With your work as the Director of Nursing, you oversee in part the inpatient unit that we have at Canon, and that's a rather unique thing. There are only 2 inpatient facilities on the counties of the Mississippi Gulf Coast, and I think it's important for our listeners to understand what inpatient hospice might be all about and who it's for.
When patients come in-house rather than in the field, sometimes they're at home and there's a problem. Either the families can't adequately control their pain, or, just a few weeks back we had a family that had to leave town for an emergency. So they can come in, and, I don't want to talk about insurances or any of that, but actually Medicare does provide every certain amount of time for them to come in-house for what we call respite. We keep them in our unit, which kind of looks like a hospital. I refrain from saying nursing home because, that's more of a long-term facility. We have 5 rooms. We have 1 private room and 4 semi-private rooms. You might cringe at that, but we have curtains between the rooms. The rooms are quite large and very nice. We provide them with meals, medications, all of the medications that they were on when they were at home. Of course, all of our interdisciplinary staff visits quite often, even more often than when they're in the field, I think, because they're just in the building. And we just spend a lot of time with them. It's a good place to be. It's a happy environment. The walls are not painted black. They're quite light orange.
In fact, the unit is newly painted and appointed with. Each patient's got a television. There's a recliner next to every bed, a telephone in every room.
Right.
And the rooms are rather large by comparison to the hospital setting.
With nice big windows.
Absolutely. Lots of natural light.
Sunny.
As much as it's possible for us to find a hybrid between a medical setting and a home environment, we try to make it as much a home-like environment as we can.
Absolutely. There are no visiting hours. Families and friends can come and stay 24/7. They can sleep, if the bed next to them happens to be empty, we've had families curl up on that bed. We have these beautiful, very comfortable recliners that they can sleep in. We've even had families come and set up an air mattress on the floor just so they can spend the night. We're very open with that. They can bring in pets to visit.
That's good for the staff as well as the patients and families, isn't it?
It is. We have a volunteer staff that also comes in. We have a man who's bringing this wonderful dog named Pepper. We also have a music therapy student who volunteers with us, and she comes and plays guitar for the patients. So there's a lot of things going on in-house at Canon Hospice to make it more homey rather than, just feel like a hospital setting.
And that said, the inpatient unit's available for those patients who are experiencing a symptom management crisis or a situation where a caregiver is having some issue with exhaustion or other pressing family business needs.
And we use that to take the opportunity to allow the family to rest, but we also take periods of that to use that time as an opportunity to teach the family member, the caregiver, maybe how to better care for their loved one.
Very good. Well, Kendall, I want to thank you so much for joining us this morning. We're going to transition now and introduce Misty Nichols, registered nurse. She's the Assistant Director of Nursing for Canon, 12 years in the nursing field, 7 years in hospice specifically. She is a Mississippi native, and she is our field supervisor. So, Misty, good morning, first of all, and welcome.
Thank you, Elise.
We're really glad to have you here. We're going to talk a little bit more about our home-based hospice services. And I think as a primer to that, it's important to say that Canon offers both home-based hospice services as well as inpatient services. And that really provides a pretty broad spectrum for covering a patient's needs. Some patients who are initially enrolled with us do remain at home, and we can provide a great deal of our services in a home environment so that a patient doesn't have to leave and come into a healthcare facility. Talk with me for just a little bit about what happens when a patient gets enrolled in the program. The nurse goes out to do an initial assessment.
That's correct. We go out and we do an initial assessment. At that time, we do an admission. We determine what is needed in the home. For instance, DMEs, durable medical equipment, and we put in hospital beds, bedside commodes, oxygen, suction machines, whatever we feel is necessary at that time. We also go over the medications, and like Kendall mentioned, we do a lot of teaching about the medications that are needed for comfort.
Good.
And we also, at that time, establish if the patient needs an aide, a home health aide, to come in.
So when a patient is admitted to hospice service, that starts, it requires a physician's order and referral. Sometimes we hear from families that they've got a loved one or they know someone from church who may be approaching the point at which they need hospice, but their own physician still makes the referral to Canon and is a part of admitting the patient to our service.
Correct. We do have a medical director, which is wonderful, and he will follow that patient if the patient's primary physician chooses not to, or if the primary physician just wants for our medical director to sort of kind of do his hospice thing. He won't take the place of the physician, but however, he will make some decisions.
So when a patient comes in on hospice service, there's an initial assessment that's done with the patient, and that is the basis for developing a plan of care for that patient.
Exactly.
And that plan of care, I imagine, can and does change according to a patient's condition and whether their symptoms advance. Who all is involved in making changes to a patient's plan of care? I know that there's an interdisciplinary team that involves a number of professionals, but everybody contributes to formulating that plan.
Well, like Kendall mentioned, we do things from a team approach. Our team is made up of our medical director, our physician, also of our registered nurses, our home health aides, and our social workers, and our volunteers. So that's how we develop the plan of care, and the plan of care being basically what it is that patient needs.
Okay. And if a patient's family member or primary caregiver can be considered a part of that team.
Right. The patient and the family member are considered a part of the team. We don't take away anything from anyone. We want the family to be involved as they would like to be.
So after that initial assessment, when a nurse goes out to determine the patient's condition and the medical records are reviewed so that we're well acquainted with their status, what could a patient or caregiver expect in terms of frequency of visits, and would that be with a registered nurse or an aide? Talk to me a little bit about the scheduling.
Well, it's determined by that patient's acuity.
Okay.
If we take a patient on that's not quite ready for daily visits per se, then the nurse generally will go out 2 times a week to determine what the patient and the family needs are. We can increase that and we can decrease that. And with the home health aide, we do the same.
Okay. And some of the things that a registered nurse would do during a visit would be monitoring their usage of medication, inquiring about any new symptoms or potential side effects to meds that they have.
And we troubleshoot, and then and we look at the things that could possibly happen.
Okay.
And we try to catch that before it happens.
Okay.
So and we monitor symptoms as far as pain control. And we teach the family about what to look for. We do have patients that cannot speak, so we teach them about what we call the FLAC scale, which is when they look at their face, they might show grimacing, they might draw up their legs, they might draw their arms up in guard. There's different things that they can look for, crying, and there's just different things. So we do, like Kendall said, we do a whole lot of teaching, especially in a home setting.
So it really begins with the power of observation and then conveying information back to the patient's family and caregivers.
Exactly, and our registered nurses are highly skilled, and they know.
How long do those visits with a registered nurse generally last?
We don't limit them.
Okay.
We do not limit them. If they need an hour, we give an hour. If they need 3 hours, we give 3 hours.
Okay.
It just depends on the patient, but there is no limit in hospice.
So much of this is patient-driven.
That's right.
Okay. You spoke a little bit ago of the aides that can come out to the home. What are some of the kinds of responsibilities that they have as they go out to see patients?
They provide baths. They do bathing, whether that be in the shower, in the chair, in the bed. We also provide small housekeeping duties if they need their trash taken out, if they need their bed changed, if they even want to start laundry. We do companionship. Mm-hmm. If the caregiver needs to go out to the store, we'll sit there for them. And they also, like when I said companionship, is in if they just need somebody to talk to, our aide will sit there and listen.
Very good. And the aide is really a critical point of communication for the rest of our staff too, because they may be in the home on a more frequent basis and observe things that one of our registered nurses would need to respond to.
Exactly. And a lot of times I found that the patient is more comfortable talking to the aide versus the registered nurse, because they're not looking at it from that RN standpoint, and they're able to convey things back to the RNs. Yes.
I think we often see that the patients and families really develop an emotional bond to people who come into the home. And there's a very warm rapport that develops between our staff and the patients that we serve.
There is. They look at us like family. Okay. We come in, and unlike the hospital where it is more of a as Kendall mentioned, more of a the nurse runs in, she runs out, because they have so much to do. We don't look at it like that. We come in and we become like family. We're more comfortable with that family. And not only do the patients get attached to us, we get attached to them as well.
Sure. Registered nurses and home health care aides are not the only staff members that see patients in their homes. I know we have a physician who makes visits out to the home, but there are others on our staff who also call on patients and families. Tell us a little bit more about that.
Well, we have our nurses are on call 24 hours a day, 7 days a week. Our social workers are the same. We also have chaplains that are available 24 hours a day, 7 days a week.
And when a patient, what's the criteria or what's a presenting situation where a nurse would need to go out to the home? They're having a crisis or they've had a fall, something of that nature?
A pain crisis, a change in a patient's status, a fall, or just if there are educational needs there.
Okay, something that's of a more emergent nature. There's no reason why a nurse couldn't go out. They're dispatched and they go out no matter whether that's on the weekend or late at night.
Correct.
Okay. And on a more routine basis, there are other members of our staff that make calls on a patient at home. We have a chaplain who makes contact with families and social workers that do as well.
We have a wonderful chaplain and wonderful social workers that are very well educated, and they also, there's times when they go out and they feel like, ooh, this is a nurse situation, and they'll call us.
Okay. Misty, I want to thank you for being part of the Canon Hospice Radio Hour. We so much appreciate your contribution here today and what you do for our staff and our patients and families every single day. When we return, we'll be joined by Dee McKeag, one of our social workers at Canon Hospice. We'll be talking about the social services aspect of hospice care. Canon is located at 1520 Broad Avenue, Suite 500 in Gulfport, just north of Memorial Hospital. Thanks so much for joining us this morning. We'll be right back. Welcome back. We're about halfway through our program. This is the Canon Hospice Radio Hour, and this morning we are speaking with members of Canon Hospice's staff to better acquaint the community with hospice services and the many different roles that are played in the hospice organization. Just a moment ago, we were speaking with Misty Nichols, Assistant Director of Nursing, and prior to that, Kendall Diaz, who is our Director of Nursing. They gave us some pretty valuable information and perspective on the nursing aspect of hospice care. Hospice is a specialty profession, and it involves many different professionals in order to best serve the patients and families who are on hospice service. We're joined now by Dee McKeag. Dee has her master's in social work, and she's a graduate of USM. She is a native of San Antonio, Texas, and her experience includes work with the Veterans Administration and the Department of Human Services. Dee, we really appreciate the contribution that you make in our facility and with our patients every day, and we certainly welcome you to the program. Good morning.
Good morning. Thank you, Elise.
Well, let's explore the subject of social work a little bit and how that contributes to taking the best care possible of our patients. In any environment where you're dealing with a population that's critically ill, patients who are dying, that's a difficult emotional experience. One of the most traumatic things that we go through is the loss of a loved one or critical illness ourselves. Tell me a little bit about how you approach this issue.
Well, first of all, Elise, no one likes to talk about death and dying, whether it's a loved one or anyone. No one likes to talk about death and dying. It is a very difficult emotion to deal with and to progress from. Individuals handle death very differently. There is no particular way to handle death. And that's where we come in as social workers. We deal with it from a psychosocial perspective, and we also work with the team approach, which does include our nurses, our clergy, volunteers, and namely the families. A lot of times, many issues that come up is families do not know how to deal with these emotions, with these different array of things that are thrown at them, all these legal questions and the personalities and the different views that every family member has and brings to the table, any unresolved issues that the person that is dying has. There's so many dynamics that have to come into play here. And part of my job as a social worker and our social work department is to help gear the family and prepare them, not just for the process itself, but to allow them that this is very natural. It happens to every one of us. Every one of us will experience death, even if it's our own. And so this is an educational time to encourage families to process these emotions that they may have. Questions that you don't go around just asking your neighbor or just talk. It's very difficult to talk about. So that's what we're there for, to help bridge that gap that they may have. And it could be even things that come to the forefront from their past that they never dealt with, unresolved loss, things like that. And one good thing about being a social worker is not only are we licensed, but we also bring to the table our baggage, if you will, or not baggage, that's not a good word, but our own experiences that we have, and we're able to assess from a different perspective and draw the person, the family to the table and say, this is how you're feeling at this moment. It's perfectly natural. It's perfectly okay. Just to give you an example, one of the things that many family members, if they have a heavy faith, one of the things that they deal with and they grapple with is being angry at God.
Sure.
That's a very natural thing. And it's easy for everyone to come in and say, oh, I'm sorry, they're going to be in a better place or whatever. Those are things that you stay away from because it's minimizing what the individual is going through. And because of the different perspectives, the dying patient has their own perspective. The guilt of not being able to have control over the fact that they don't want to leave their loved ones or having the loved ones see them go through this experience, the pain, the suffering, the whatever issue it is. And then there's the family has the different perspective of not wanting to let go, or sometimes wanting to let them go, but that guilt. Mm-hmm. I feel bad that I want my mom to die so she won't be in pain anymore. And there's the ambivalence there.
Mm-hmm. Well, even in a church setting or in our neighborhoods, when we learn that someone has passed or is critically ill, we really struggle with what to say. And I think sometimes it comes out of an area of concern and empathy that we want to soothe the person that we're speaking to.
And that's naturally instinctive, naturally.
Yeah. Even in situations with a patient, our inclination is to encourage people to eat because we believe that that's associated with a person's strength and vitality. And so some of what we know or believe is sometimes counter to what patients and families need.
Exactly. And just to piggyback on what you just said about the family naturally wants to encourage the member to eat. It'll make you feel better, or you need your nutrition, et cetera, et cetera. But the truth of the matter is that the patient is in fact dying, and their decreased need for food or drink is very much part of the process. Mm-hmm. And that's a teachable moment for the family. Sure. Because they know nothing else, and that this is everything that you've grown up knowing. Mm-hmm. So to realize now that no, actually it's a very natural part of a process that they have to go through. And when you educate the family member on that, then they know. And again, that alleviates a lot of any guilt they may have because well, I want mom to eat because it'll make her feel better. Well, in fact, it's just contrary. It really does not make them feel better. They don't have that capacity for that because they no longer need the nurturing. They're in the active process of dying.
Their bodies are no longer not only not desiring it, but not being able to physically tolerate it or process nutrients.
And they don't need it anymore. That is the way the body is saying, I no longer need it because I'm moving on to the next phase.
Yeah, that's so hard for us in our culture. We really do believe that we want to promote food, and we have wonderful food in South Mississippi that's part of our culture and tradition. we associate sadness as, I guess, or at least I do, the primary emotion connected to death of a loved one, but that's only a part of the spectrum of emotions that someone experiences when they're in this
exactly.
situation.
The emotions are so varied, and I touched on it earlier. Much of it could be guilt of unresolved issues, of things that weren't said, would have, could have, should have, or maybe what I did say and now I can't take it back, and now my loved one is dying and they're in the active phase, so they're not able to hear what I'm saying. Mm-hmm. So and then there's the guilt of, I don't want to see mom suffer anymore. I don't want to see her with another IV and with another whatever, that I want her to move on. So there's so much guilt. And I would think that probably, in my opinion, the largest emotion that there is to deal with is guilt, but also sadness. But it's all in your perspective. And I think one of the things that we bring to the table also as social workers is to allow the family permission that it is okay to feel all these things. Not only is it okay, it's very natural to feel these things. And family members feel so guilty for feeling this way, and yet it's very natural. And they need to be nurtured in their own way, that this is perfectly natural. There's nothing wrong in you feeling this way and thinking these things. And there's just a lot of validating that goes on, validating a person's emotions, the family. A lot of validating, a lot of listening. Anyone who experiences a death, one of the best things that I would encourage anyone to do is listen. Yeah. They don't need to know that they're in a better place, first of all, because they may not believe it, and they don't care. They are missing their loved one. So they don't care that they're in a better place, because that is my loved one that I lost, and I am missing them.
It kind of touches on something that Misty and Kendall talked about before, the power of observation and the wealth of information that comes from simply listening and observing and being present. It's an important component of social work services for our patients and families.
Exactly. And if I could, just also, one of the things that they touch on as far as observation, it's not always what's said. Many times it's what's not said. So when you're observing the family, it just as many times it could be what is not said.
Is grief the same thing as sadness, or is it something different, or maybe it encompasses sadness?
Well, it does encompass sadness. And grief, again, and I think I touched on this earlier, but grief is definitely individualized, and it brings a lot of things to the table. It brings the emotional side of it, how we're going to react physically, mentally, how we're going to deal with it. And sadness is a part of it. Grief is very personal. There is no specific way to grieve, and that's what people need to know. Oftentimes, when a person is in denial and not ready to let go of the loved one, people do not all cry. And so people think, outside looking in, they think, well, gosh, she didn't even care. She's not even crying. And yet, it is different for everyone. And grief is individual. It's at a different pace. There is no time frame. Some people grieve for 2 weeks and then somehow move along, and that's their coping skill. And whether it's right or wrong, it is individual, and that's what we need to remember. That grief is it's layered with multi-layers and with different aspects that come to it. So grief is sadness, but it's not all encompassing sadness. Okay. It's mourning.
When we talk about grief, sometimes we have a particular difficulty in understanding how children handle a grief response. When children are grieving, what are some important things to remember about taking care of a grieving child?
That one's a tough one. First of all, the concept of death is, as an adult, is hard to accept anyway. So multiply that by 100 for a child. I'll tell you what we don't need to do. When you deal with a child, we need to address death in concrete terms for a child. They do not need to be told that mom is going to be sleeping, or she's away, or she's with God, or things like that. Because in that child, things concretely. And so if that child is told they're with God, well, I want to go there too, and why can't I go? Mm-hmm. So a child needs to be instructed or educated in concrete terms as far as death, that mommy's body is not working anymore. and we can't fix it. I'm not saying you have to be.
I think with children, it's probably counter to our intuition, but it's okay for children to see that we don't have all of the answers.
We don't have the answers, exactly, and it's okay for them to understand that sometimes it's okay to just say, honey, I don't know. Yeah. I don't know why. Yeah. Because we don't have all the answers. And so dealing with children, I would encourage everyone to just reiterate that it is a permanent process. And, they don't need to be told that they're in a better place or whatever, because, again, the child thinks childlike, and so I want to be there with them. I miss them. Why can't I go too?
Okay. Just one more quick question. We'll be going to break here in just a moment, but is it all right for children to see us in our grief? Okay, for our children to see us cry?
I think they should, because first of all, what you're doing is you're normalizing it. You're letting them know that there's nothing wrong with showing that you cared for this person. So yes, I would strongly encourage that. Now, the concern that I would have is when it becomes so debilitating that you cannot function. That would be the difference there. But
And
yes,
there are counselors and professionals who can assist individuals that have protracted or debilitating grief.
Exactly.
Okay. We're going to be back in just a moment with our guest, Dee McKeag, social worker for Canon Hospice. Thanks so much for joining us this morning. We'll be back with you in just a moment. This is the Canon Hospice Radio Hour. My name is Elise Spencer. I'm your host this morning. We are joined in the studio by several members of our Canon staff. Kendall Diaz, Director of Nursing, Missy Nichols, Assistant Director of Nursing, and right now we're speaking with Dee McKeag, social worker for Canon. Before the break, we were speaking about the concept of grief and the topic of sadness, and we addressed a few questions about how children process grief. And there are some other recommendations that you can offer as a general guideline for responding to children who have suffered the loss of a loved one.
Yes. For example, one of the things that I'd like to touch on is when the loved one that is dying is the parent. The child's sense of security or even survival is going to be impacted for the rest of their life, and this is going to set their tone for how they deal with many other things that will come their way as an adult. One of the things that I'm asked about all the time is, should I force my child to attend a funeral? And it's not always in the best interest of the child if they don't want to go. And it's okay if they don't go. As an adult, we want to jump in and say, you'll never see them again, and this is the last time for you to say goodbye. But children are very resilient, and they find whatever works for them to say goodbye. So I would encourage that if that's something that you're pondering, do I need to force them to attend the funeral? No, they don't need to go. Children grieve differently just as adults do, and it's perfectly okay if they do not attend the funeral. As an adult, I can understand why we would want them to, but again, I don't think it's necessary, and the grief that the child is going through needs to be assessed. And there are professionals that help with that.
Well, what are some common reactions to loss as adults? What do we see?
Well, something that is very common, and Dr. Elizabeth Kubler-Ross identified this. It's called stages that are very common that everyone goes through, and most of it is going to start with the person is in denial. They experience numbness or disbelief that this is even happening. Anger, being angry. I know I touched on this earlier, being angry at God, for one, but being angry at themselves, being angry at others, and even the patient experiences anger in the sense that if I would have just gone sooner to the doctor, or if I would have listened, or if I hadn't ignored my pain, or whatever. So anger is very common also. These that have been identified by Dr. Ross they're common, but they're not necessarily in any order, and they're not all experienced. Bargaining. If I'm cured of this, I'll never do this again, or I'll never go there, or whatever. So bargaining comes into play. Depression, of course. Depression, the sadness, crying, feeling despondent, feeling the disappointment. Whiny,
Sure.
and the all that is the depression, part of the depression. Acceptance and coming to terms with the loss and the death, that's probably the most critical part, because it'll set the tone for what will come and how you will deal with things when these things have started to settle down. Once you start accepting things, and then you can move forward. And for the most part, you will not be able to move forward until you reach that point that you have come to terms with the fact that this has happened to you, whether it's right, wrong, fair, or not. You're at a place where it's a done deal, and I need to move forward, and I can't move forward until I come to that acceptance term.
As neighbors, friends, extended family members, when we see someone through our church or our community organization, someone in our family that appears to be experiencing a long period of depression or a sense of helplessness or anger about a loss, what can you say as a friend, as a daughter, as a fellow church member? What can you say to encourage people who are really still very gripped by their grief?
Sometimes the best place to start is with the person that died. For example, I know that you miss Harry, and he was such a wonderful man. Talk about that person, because that person that has suffered the loss is still not in tune with that this is a forever thing, or they're not ready to accept that it's a forever thing. And if I forget Harry, then everyone else will. So I don't want everyone to forget Harry and the wonderful person he is. So sometimes it's not always what you say, but sometimes it's what you don't say. But in this case, I would encourage someone to speak of the loved one, and remember, just let that person remember that they were very much a part of your life. And oh, he was so funny. Do you remember this? Just recall little incidents of time that they had when they were alive. And I think that does much to bring the person towards the acceptance, the normalizing of the fact that Harry will never come back again. But we can remember what he did give to us. And it's not always good. So it's okay to touch on the bad also, because guess what? Harry was very much human being.
Sure, as we all are. But it's okay to say the person's name.
Sure,
recall
yes.
events
Right,
that involved
right.
him, or something special about
Right.
the person that's missed.
Right, sure. And I think that talking about it so much gets to the point where it makes it feel very normal. It makes me feel sane. I haven't lost it. I'm still intact. I'm hurt. I'm in pain. I'm grieving. But yes, I'm not the only one that remembers Harry.
Okay. Well, taking it back into the scope of what hospice services encompass, one of the services that is provided is bereavement. Mm-hmm. Tell us a little bit more about that.
Well, first of all, bereavement is a period that someone goes through after the loss of the loved one. So this is the mourning period, if you will. It's when they start feeling a varied number of emotions, or lack of emotions. It's when they the numbness, the shock, the relief, the depression, sadness, acceptance. All these are part of the bereavement process. And because we recognize how important bereavement is to the family and the loved ones, Canon Hospice does the social work department, and in fact the whole Canon Hospice team, we do follow the family members for a year. So we are very interactive with the family. We call on them. We whatever it takes to help them through the process, whether it's resource referral, whether it's a home visit, a phone call, just letting them know, that we didn't just treat your patient. Your patient was our family member too. And so we haven't forgotten, and we're here with you still. And do you need our clergy? Do you need the social worker? Whatever it is. So that's one thing I really like about our Canon Hospice social work department, and actually the whole Canon Hospice team, is that we do follow our family for a year. And help with any transitioning, any validating, any encouragement, a lot of times, just the listening.
Well, it's really valuable to know that your loved one, whom you miss quite a lot, is remembered, thought of, honored.
Right. And also with that, I'm sorry, one of the things that we also do is every year we have a service, a
A celebration of life
Yeah,
service.
exactly. The celebration of life service, where we recall, we remember the patient, and so that's something also endearing to the family members. That this is not just a number that we treated. This is an individual that came into our lives, became part of our Canon Hospice family, and we helped you process and continue to help you process. And that's what makes us so unique in that we are vested in this patient and the family.
It is hospice is certainly a medical specialty, but there are very many differences between traditional curative therapies, and one of the places that is most clearly seen is that concept of caring for, coming to surround and support a family during the final phase of a patient's illness, but having that care continue after the patient dies.
Right. Mm-hmm. It doesn't end. When the patient dies, our services do not end. We continue. We continue, maybe not directly for the patient, of course, but with the families. We continue following the family for a year.
I think as I go out in the community and I talk about hospice services, it is such a difficult thing for people to take the first step to make an advance directive or make their family members aware of what they would want to have done in the event that they're not able to make their own medical decisions. It's really a critical conversation to have, and by saying the words, taking that step, it doesn't mean that it's imminent. It's just a manner in which as individuals we can make our needs known, and it's also a gift to our families.
Well, and I'm glad you mentioned that, because just recently, in fact, I had a family who they're having difficulty with their loved one, and it's such a difficult topic, and it's so new to the family. They've not had to deal with death before. So what a social worker also brings to the table is normalizing, if you will, the topic. It's a different perspective than I'm not coming as a parent. I'm not coming as the a child. I'm coming as a third party, very matter-of-factly, but still delicately, and asking, what are your wishes? The family was not willing to go there. It's still so painful. And,
Sure.
and then they think, oh my gosh, she's talking about a funeral home. That must mean 24 hours or whatever, which it doesn't. But these are things that need to be addressed. And part of the social work team effort is to bring that to the forefront and to not leave any stone unturned in regards to the wishes of the loved of the patient, whether it's to be cremated or buried or whatever it is. Those are difficult topics to, especially when the person is still alive, that you're addressing.
Yeah.
Very difficult, but it is a necessary evil.
While we're able as adults to make some of those distinctions and discern what we would want in the event that we would have an illness or an accident, it's really a gift that we can give to our families, our loved ones, to not leave them in a place where they are wondering if what they are doing is in compliance with what we want.
Sorry, when you say that it's a gift, it really is a gift. And so you might wonder, well, how is it a gift? Well, the gift of knowing, the gift of this is what mom would want. There's no second guessing. There's no thinking it wrong or did I make the right choice?
No quarreling among
Right,
siblings.
no. Mom was very clear. This is what she wanted. These are her wishes. However I feel about it, these are her wishes. So yeah, that is a gift. The gift of peace of mind.
Well, death is part of the cycle of life, as Kendall said earlier in the program. And, as medicine advances, we see that, it's much different than it was 100 years ago, where people were, might succumb very quickly to a cardiac condition or a respiratory condition. Medicine has advanced, and many people are living a very long and still a healthy life with chronic conditions. And that's how hospice, has come into being. And it's important for us to share our commitment and our mission with the community. That extends to the type of thing that we have just been speaking about. There is information available through Canon Hospice that can assist you with making your medical directive or making your needs known, wishes known to your family, your physician, and those that are involved in your health care. We encourage you to take that step, and the staff members of Canon Hospice have that commitment to share the information and to support any family within our community who is dealing with an end-of-life or life-threatening illness issue. Consultations do begin with a patient's physician. However, we do encourage families, loved ones, friends, to contact us if you simply need more information. It doesn't mean that there's a commitment involved. We are happy to share the information with anyone who requests it and, if necessary, guide an individual or a family through the process of admission. I want to thank all three of my guests: Kendall Diaz, Director of Nursing at Canon Hospice, Misty Nichols, Assistant Director of Nursing, Andy McKay, our social worker. Canon's located at 1520 Broad Avenue, just north of Memorial Hospital in Gulfport. Our phone number is 228-575-6251. Thank you so much for being with us. We want to thank Mississippi Media Broadcasting for the opportunity to broadcast this morning, and thank you to Chuck, our production engineer. Have a good week, and we'll be back with you soon.